everyone, Assalamu alaikum. This is Dr. Tazeen and I'm here with Study EFOG-EBCOG Triple R series, which are actually designed to prepare you for your exam, which is upcoming March 2025 exams. So today's session is about oncology, and we will see that what are the important areas which we have to cover in oncology and how to go about in oncology. So I welcome you all for this session of Triple R series. If you have not subscribed the YouTube channel of StudyMEDIC, subscribe now and just click on the bell icon so that you are updated with all the upcoming series. So before start of the session, the message for all of you is that keep your passion and dedication alive. This is the key ingredient of your success. And last few days, keep all excuses aside and just remember one thing, that you are capable of clearing this exam in one go, and definitely you will do that. So first of all, talking about cervical screening, one thing we have to remember for cervical screening is that routine HPV screening can begin at 35 years of age or above. Routine HPV primary screening should not begin under 30 years of age, and the available evidence is insufficient to recommend or against beginning routine HPV primary screening in the age range 30 to 34 years. Absence of sufficient evidence on the optimal age at which to stop screening, HPV primary screening could stop at the upper age limit recommended for cytology, which is the primary screening 60 or 65 years. And one thing you should be very clear, that when we have to stop the screening, the woman should be compliant with the previous screening and she should have recent negative tests as well. The European guidelines recommend that invitation to cervical cancer screening begins between 20 and 30 years of age. The only primary screening test currently recommended by the European guidelines for the cervical cancer screening in women under 35 years of age is cytology. The screening interval of women with negative HPV primary test result should be at least 5 years, but it can be extended up to 10 years depending upon the age and screening history as well. So there are certain risk factors for cervical pathology or cervical cancer which should be kept in mind. And the major risk factor is early onset of sexual activity as well as multiple sexual partners. Sexually transmitted human papilloma virus, there are approximately 250 HPV types, out of which 20 are high risk, which cause 99.5% of the cervical cancer cases. In Europe, the most common subtypes are found in cervical cancer are HPV 16 and 18, and these two subtypes cause about 75% of the cervical cancers, and other HPV types are 31, 33, 45, and 52, which can be associated with cancers as well. Then low socioeconomic status is also very, very important. Cigarette smoking increases the risk by 50%, and oral contraceptive pills risk is significantly increased in women who have taken the pill for at least 10 to 15 years, and the increased risk of cervical cancer begins to drop as soon as the pill is stopped. Then when we are actually, there are certain cytological classification which we should keep in mind, that it can be negative for intraepithelial lesion or malignancy. Squamous epithelial cell abnormalities can be there, like atypical squamous cells of undetermined significance can be there. And then low grade squamous intraepithelial lesion can be there, high grade squamous intraepithelial lesions can be there. Then squamous cell carcinoma, glandular cell abnormalities can be there, atypical glandular cell, endocervical, endometrial, or not otherwise specified can also be there. Atypical glandular cells who are favoring neoplastic changes, adenocarcinoma in situ or adenocarcinoma can also be there, which should be kept in mind. Then there comes the colposcopy, that after cytology, what is the other test? We know that cytology can be among the primary screening, or HPV screening can also be done, or liquid based cytology can also be carried out. But one thing we have to remember, that cytology is preferred under 35 years of age by European guidelines. Moving forward to colposcopy, that is basically if there are some changes, that abnormal cervical screening is there, that results actually is guiding us that further investigations and further testing is needed, and that further testing is colposcopy, colposcopic examination of the transformation zone. Colposcopy was initially used as a primary screening tool for cervical dysplasia, but now we know that colposcopy is unsatisfactory method of primary screening. However, it is useful method of differentiating between normal and dysplastic epithelium when screening cytology or the HPV tests are positive. So it is one step ahead. First, we will be doing cytology or HPV testing would be available. If there are any abnormalities, then we are moving forward to the next step, that is colposcopy. Standardized description of colposcopic abnormalities should also be used, namely the nomenclature published by International Federation of Cervical Pathology and Colposcopy in 2011. This should be kept in mind. So then there are certain changes which we can see that what would be the colposcopic changes can be there. It generally it can be adequate or inadequate for the reason that we are able to visualize the transformation zone or we are not able to visualize the transformation zone. So we can say that colposcopy is adequate or colposcopy is not adequate. Squamocolumnar junction visibility is very, very important, and also the types of squamocolumnar junction, like type 1 can be easily visualized. Type 2 we can find some difficulty, while in case of type 3 there can be difficulty in visualization of transformation zone. Normal colposcopic findings can be original squamous epithelium, mature cells can be there, atrophic changes can be there, columnar epithelium can be there, ectopy can be there, metaplastic squamous epithelium can be there, Nabothian cysts can be there, or crypts, glands, openings can be there, or deciduous changes can be there in pregnancy. Abnormal colposcopic changes can be generally, basically, that is the location of the lesion, that where actually the lesion is located, inside or outside of the transformation zone, location of the lesion by clock position, and size of the lesion, number of cervical quadrants the lesion is covering, and size of the lesion in percentage of cervix. Then it can be divided into grade 1 minor, grade 1 major. The grade 1 minor is acetowhite epithelium, irregular geographic borders can be there, or fine mosaic patterns or fine punctations can also be there. In cases of grade 1 major, that can be dense acetowhite epithelium, rapid appearance of acetowhitening, cuffed crypts, openings can also be there. Then coarse mosaic patterns can be there, coarse punctations can be there, sharp borders can be there, inner border sign can be there. Okay, and then there can be non-specific changes, which we can say that this can be leukoplakia, keratosis, hyperkeratosis, erosions, lugols. Staining can give us the results that whether it is stained or non-stained. Then there comes the suspicious lesions. Suspicious lesions are always that which are showing the atypical vessels. Additional signs can be these vessels, they can be fragile, irregular surface can be there, exophytic lesions can be there, necrotic lesions can be there, ulcerations can be there, tumors or gross neoplasms can be there. So we can say that these lesions are basically they are suspicious for invasion. And then miscellaneous findings like congenital transformation zone, condyloma, polyps can be there, ectocervical, endocervical, inflammation can be there, or there can be stenosis which can be congenital anomaly. Post-treatment consequences can be there, as stenosis of the cervix or endometriosis can also lead to stenosis. So all these changes, they can be there, all these changes, they can be present when we are doing the colposcopic examination of the woman. All right, so moving forward, that whether these are low grade lesions or high grade lesions, and the management of these lesions, it will depend on that. If it is low grade cervical intraepithelial neoplasia, then it is usually associated with low potential for progression and frequently regresses spontaneously. And patients with low grade lesions, they can be followed, and the therapy is usually not necessary, as most of the lesions, they are self resolving as well. High-grade squamous intraepithelial lesions, the spontaneous regression rate in case of cervical intraepithelial neoplasia type 2 is in immunocompetent patients, it ranges from 40 to 60%. Conization in women with high-grade squamous intraepithelial lesion or cervical intraepithelial lesion type 2 who are still planning future pregnancies is not recommended unless this finding persists for 2 or more years or progress in severity. Ablation methods are also there: cryotherapy, laser vaporization, electrocauterization, and thermocoagulation. Excisional lesions are also there: cold knife conization, and electrical loop or loop electrosurgical excision procedure, or LEEP, or carbon monoxide lesion. Adenocarcinoma in situ conization is necessary to ensure that no invasive disease is present, or if the patient's family is complete and no fertility concerns are there, then we can move for hysterectomy as well. So after the treatment, when once we have treated the patient, so what actually should be done? That women should abstain from sexual intercourse for 3 to 4 weeks until the cone bed has healed. Post-incisional testing starts at 6 months after conization, which we call as test of cure. Irrespective of margin status, this follow-up should include HPV testing and cytology. And if the results of HPV testing are negative after 6 and 24 months, the SIN2 risk within the next 10 years is 0%. However, if the high-risk HPV is detected after 6 months, then the risk of SIN2 is significantly higher, which is up to 28.2%. As previously mentioned, the high-risk human papillomavirus testing after treatment is more sensitive than margin status in predicting treatment failure, 91% versus 56% with equivalent specificity. Therefore, positive margin status should not be the sole reason for reconization, and the value of reporting margin status in the absence of microinvasive disease is still under evaluation. Now, moving forward to ovarian cancer, we will see that what are the various stages and how to go about stage-wise management of ovarian cancer. So first of all, if we have a look that when we say that stage 1, that is the tumor which is confined to ovaries or fallopian tubes, okay, that is 80 to 90% is the 5-year survival rate. Then in stage 1, it is further subdivided into stage 1A, 1B, and 1C. 1A is tumor limited to one ovary or fallopian tube, and the management of this would be fertility sparing only in low-grade tumors, unilateral salpingo-oophorectomy plus peritoneal biopsies plus lymph node dissection. If the family is complete, then primary debulking surgery with residual disease can be carried out. 1B tumor is limited to both ovaries or fallopian tubes, so the management would be primary debulking plus adjuvant chemo in grade 3. And 1C is further subdivided into 1C1, 1C2, and 1C3. That depends upon the spillage. So tumor, if it is limited to one or both ovaries with any of the following: if it is surgical spill, that would be 1C1. If the capsule is ruptured before surgery or tumor is on the surface, that would be 1C2. And 1C3 is the malignant cells in the ascites or peritoneal washings are present. And the management of this stage would be primary debulking plus adjuvant chemotherapy. Moving forward to stage 2. Stage 2 tumors involve one or both ovaries or fallopian tubes with pelvic extension below pelvic brim, or peritoneal cancer can also be there. 65 to 70% is the 5-year survival rate. In case of stage 2A, which is the extension to the uterus or fallopian tubes or the ovaries, primary debulking surgery plus adjuvant chemotherapy can also be done, or neoadjuvant chemotherapy with interval debulking surgery can also be carried out. In cases of stage 2B, which is extension to the pelvic intraperitoneal tissues, primary debulking plus adjuvant chemotherapy or neoadjuvant chemotherapy with interval debulking can be carried out in cases of stage 2. In case of stage 3, this tumor involves one or both ovaries or fallopian tubes or peritoneal cancer with confirmed spread to the peritoneum outside the pelvis or metastasis to the retroperitoneal lymph nodes. 30% is the 5-year survival rate. 3 3A1 is positive retroperitoneal lymph nodes, 3A1 metastasis up to 10 mm in greatest dimension, and 3A1 the second type is metastasis which is more than 10 mm in the greatest dimension. Primary debulking plus adjuvant chemotherapy or neoadjuvant chemotherapy with interval debulking would be the management in these types. Stage 3A2 is microscopic extrapelvic peritoneal involvement with or without positive retroperitoneal lymph nodes. Primary debulking surgery or adjuvant chemo or neoadjuvant chemotherapy with interval debulking surgery would be the management in this case. Stage 3B would be macroscopic peritoneal mets beyond pelvis up to 2 cm in greatest dimension with or without metastasis to the retroperitoneal lymph nodes. Primary debulking surgery, adjuvant chemo or neoadjuvant chemotherapy with interval debulking would be needed in this case. Stage 3C is macroscopic peritoneal metastasis beyond pelvis more than 2 cm with or without metastasis to the retroperitoneal lymph nodes. It includes extension of the tumor to capsule of the liver. Always remember 3C is capsule of the liver, not parenchyma of the liver. Okay, so it is a tumor to the capsule of the liver and spleen without their parenchymal involvement. When it would be parenchymal involvement, that would be stage 4. Capsular involvement is stage 3 and neoadjuvant chemotherapy with interval debulking surgery would be the treatment in this case. Stage 4 is distant metastasis excluding peritoneum. Neoadjuvant chemotherapy with interval debulking would be the treatment. Stage 4A is pleural effusion with positive cytology. So neoadjuvant chemotherapy with interval debulking we would be going for. And stage 4B, as we discussed, that this is parenchymal and extra-abdominal metastasis, inguinal lymph nodes or lymph nodes outside the abdominal cavity. And the management in these cases would be neoadjuvant chemotherapy with interval debulking surgery. So I hope this will help you to make it easier to go through stage-wise and stage-wise management of these cancers. Moving forward to vulval cancer, stage 1 is tumor which is confined to the vulva. 1A is lesion up to 2 cm in size with stromal invasion up to 1 mm and no nodal metastases are there. So wide local excision can be carried out in these cases. Stage 1B is lesion which is more than 2 cm in size or with stromal invasion of more than 1 mm with negative nodes, radical vulvectomy by triple incision with tumor-free margin of 8 mm or more, plus sentinel lymph node procedure can be done. If sentinel lymph node is negative, then ipsilateral inguinofemoral lymphadenectomy must be done. If ipsilateral sentinel node is positive, complete bilateral inguinofemoral lymphadenectomy is recommended. Stage 2 is tumor of any size with extension to lower third of urethra, lower third of vagina, anus, and negative nodes. Stage 2 is treated with radiotherapy or without concurrent chemotherapy followed by radical vulvectomy. So radiotherapy with or without concurrent chemotherapy, then it would be followed by radical vulvectomy. Moving forward to stage 3 tumor of any size with or without extension to the lower third of urethra, vagina, anus with positive inguinofemoral lymph nodes. Stage 3A is tumor of any size with or without extension to the lower third of urethra, vagina, and anus with positive inguinofemoral lymph nodes. One lymph node metastasis 5 mm or more, and then 1 to 2 lymph node metastasis in second stage is there. Okay, so radiotherapy with or without concurrent chemotherapy followed by radical vulvectomy. Stage 3B is 2 or more lymph nodes metastasis 5 mm or more, and in other type 2 or 3 or more lymph nodes can be there, and the management would be radiotherapy with or without concurrent chemotherapy followed by radical vulvectomy. And 3C is basically positive lymph nodes with extra capsular spread. So again, the management would be radiotherapy with or without concurrent chemotherapy followed by radical vulvectomy. Stage 4 is tumor which invades upper 2/3 of urethra, upper 2/3 of vagina or distant structures 4A is tumor invades any of the following: upper urethra, a vaginal mucosa, bladder, rectal mucosa, or fixed to pelvic bone. Fixed or ulcerated inguinofemoral lymph nodes are there. Biopsy followed by primary radiation with or without chemotherapy. If incomplete response to radiation, nodes may be resected as well. 4B, any distant metastasis including pelvic lymph nodes. Biopsy followed by primary radiation with or without chemotherapy. If incomplete response to radiation is there, then nodes can be resected as well. Sentinel lymph nodes are identified using both radio-labeled technetium and blue dye. Indications of sentinel node procedures are unifocal tumors confined to vulva, tumors 1 mm, okay, and then clinically negative groin nodes. That can also be an indication that we have to go for sentinel node procedure. So this was all about oncology RRR series. If you have not subscribed the YouTube channel of StudyMEDIC, subscribe now and go through this series, and this can be quick revision for your exam preparation. I wish you all the very best for your upcoming exams. Thank you.